Very good evening. Warm greetings on behalf of iTruth. I am BM Zeeshan Hameed, Associate Professor from KMC Manipal. iTruth is an international group of urologists. It stands for International Training and Research in Uro-Oncology and Endourology. The core ethos of iTruth is dissemination of knowledge and quality education among urologists. To fulfill this objective, we started conducting webinars involving diverse and interesting topics. Today's webinar is on changing trends in urology. We have expert urologists from India and UK sharing their insights on recent training, webinars, research, uro-oncology, and endourology. We have a mix of young guns and seasoned urologists who will share their experience. I take this honor to introduce our moderator, Professor Ravindra B Sabnis, who is the Director and Head of the Urology Department at MPUH Nadia. He is known as Master Teacher and he has trained numerous urologists in India and abroad. He was the President of West Zone USI, Secretary of Urology Society of India, and Chairman of Board of Education. He has received various awards, including Best Teacher Award by NBE, Global Leadership Award by American Urology Association in 2019. We have Dr. Tushar, who is a young, energetic urologist from All India Institute of Medical Science, Rishikesh. He completed his MCH Urology from prestigious PGI Chandigarh and MS in Surgery from All India Institute of Medical Science, Delhi. He has done his fellowship in robotic surgery and uro-oncology from Rajiv Gandhi Cancer Institute and Research Center, New Delhi. He has various publications and recently published an article on uro-oncology in times of COVID-19 with Indian Journal of Cancer. I take this pleasure to introduce my good friend Abhishek Singh, who is the rising star of Indian urology. He is a consultant urologist at MPUH Nadia. He is also a fellow of World Endourology Society and council member of Youth Organization of USI. He has received various awards and accolades, including HS Bhatt Gold Medal, GM Phadke Traveling Fellowship, Dr. Sitaraman Memorial Best Essay Prize. He has also received Traveling Fellowship from Endourology Society and Japanese Urology Association. He is also the member of Editorial Board of Indian Journal of Urology. Dr. Rajeev TP is the Honorary Secretary of Urology Society of India. Dr. Rajeev has also been the Treasurer of Urology Society of India. He has received Gold Medal from MCH Urology training during his training in All India Institute of Medical Science, Delhi. He has done fellowship from University of Minnesota in US in the field of endourology and robotic urology. And he is also a visiting faculty at University of Minnesota. He is instrumental in bringing USI to the global platform by conducting various webinars and first full-day virtual youth conclave this year. Dr. Rajeev is a go-getter and has brought a lot of positive initiatives to the Urology Society of India. He is also the Honorary Secretary of SARC Urology Society. I would like to introduce the ever-charming Dr. Amelia Pietropaolo, who is Associate Specialist at University Hospital, Southampton, United Kingdom. Her field of interest include endourology and urolithiasis, and she has completed her fellowship in the same field. She has also been awarded twice with the Best Paper in Literature from ULIS in 2017 and 2019. She is deeply involved in research, and she is also an active member of the Young Academic Urologist Group of EAU. I would like to say that I would also congratulate her for being the chairperson of the prestigious Endourology and Urolithiasis Group.
Rajeev Kumar from All India Institute of Medical Sciences. He is Associate Dean and Professor of Urology from AIIMS, New Delhi. And then we have Dr. Gagan Gautam, Director, Department of Uro-Oncology and Robotic Surgery, Max, Saket, New Delhi. So I think our first speaker for the day is Dr. Abhishek, and he'll be talking on online training and webinars. Dr. Abhishek, over to you.
Okay, is my screen visible?
Yes, sir, you are visible and you're audible.
Yeah, a very good afternoon to all the viewers. I am Dr. Abhishek Singh from Multibhai Patel Urological Hospital, and warm greetings from Nadia. I thank Dr. Bhaskar Somani and Zeeshan for this wonderful opportunity and congratulate iTruth on this venture. We would be discussing changing trends in urology in 2020, and I would be talking about online training for MCH and DNB, what has changed. My disclosures are that I am co-investigator for the survey that I would be discussing, so may have investigators bias. What has changed? Definitely our attires have changed. The classrooms have become empty, and all the tete-a-tete and private conversations are now virtual. So this is what has actually changed. So let us follow the change. During the course, I would be talking about online mock exams, simulation-based training in today's era, experimental learning, and innovative teaching. So basically, this all started with a program of physical mock exam that we had planned in the 3rd week of March. Unfortunately, there was a lockdown situation, and we decided to shift the entire program online and called it the online mock exam. All 130 students that had been enrolled for the physical exam got shifted to the online mock exam, and we used the Microsoft Teams platform to conduct the same. It was conducted over a period of 4 days, and in each day we had 6 hours of training divided into 2 sessions. The components that we evaluated were case discussions, instruments, operative surgery, radiology, pathology, and we had a lecture at the end of the day. This is how the Teams Microsoft platform actually panned out. The advantage was we actually created a virtual classroom, and the candidates could just enter this classroom 5 minutes prior to the onset of the program. This required no ID or password once he had been registered for the class. There was a chat box feature which allowed to put them the questions, and there was a file transfer options where the candidates could exchange data between them. So that worked in favor of an online exam. Teams now at this point in time has a virtual classroom which actually looks like this. This is already the trial for this particular classroom has been completed, and it will be launched. So we can actually see the people sitting in the classroom when you use the Teams platform. This is not the only platform. What has changed is that Geo has brought up a Geo Glass, basically has brought up a software wherein you can see the teacher as a hologram, and the teaching will become more effective or interactive, if you could say so. So how was the exam conducted? Basically, there were 3 examinees and 4 examiners, and then the interaction between them started on the basis of case discussion initially. So let's see a video how this panned out.
Of fatigability, breathlessness, edema. So that I think I need to know that.
That is important. Anything else?
So we have to look over the external genitalia, sir, because.
So you can see how the interaction between the examiner and the examinee was as if it was not actually on the online platform, but on the physical platform. Let's see how it panned out when the faculties were trying to answer what the examinees asked.
Because as up to almost 4 to 5 centimeters above symphysis pupil, it can be chronic retention, and there can be chronic bladder changes also, so we can suspect.
No, that is not the answer I was looking for, because retention and chronic retention are differentiated on history. If the bladder is tense.
So with this slide, I was trying to bring out the point that the interaction on an online platform was quite impressive when you compared it to the physical platform. So how did the candidates get evaluated? They were not evaluated or marked on a scale, but they were given a summative feedback at the end of their performance, what they lacked, how they could improve. So this was not a scaled evaluation, but a summative evaluation, I would say. Then how effective is the online mock exam? To find this out, we conducted a survey. We developed a survey which basically compared the online and the physical mock exam. We built it up on a SurveyMonkey platform, and it was validated. There were 16 questions, 11 questions were matrix type, for which the candidates had to mark or rate from 1 to 5, with 5 being the best. Majority of 130 students who attended this particular program had actually attended a physical mock exam. Now just look at the questionnaire. First, we asked whether they had actually attended a physical mock exam, and then came the matrix question, where we asked them, was it easy to understand the examiner's question, followed by the explanation? Was the fluency of interaction good between the examiner and the examinee? Were they able to concentrate? Did they feel involved? And was their ability to interact amongst peers? We also asked them regarding distraction. Then again, we put in another matrix question where we ask them about logistic convenience, ability to balance their daily work, peer motivation to concentrate during the course, and ability to network. And did the whole thing actually fulfill their expectations? After this, we wanted to know whether the technical support and the internet speed did it matter to them. And finally, we asked them whether they would recommend it to others or not. So what the survey resulted into? Actually, out of the 119 respondents of 130 candidates, 103 had actually attended a physical mock exam. So it was fairly evened out. When we discuss, when we actually calculated the statistic, we did the statistical analysis for individual questions regarding ease of understanding the questions. Both online and physical examinations were comparable. With regards to ease of understanding the explanation, fluency of interaction between the examinee and the examiner, ability to concentrate for a long time, and feeling of involvement. All these factors, online exams scored better than a physical exam. The ability to interact with amongst the peers was better in the physical exam as compared to the online exam. The distraction was lesser in online exam. So, and it was logistically more convenient, and all candidates could actually balance their routine commitments on an online platform. The peer motivation to concentrate was actually more in the physical setting than the online setting. And the ability to network with the peers was more on the online platform. This difference can be because of the chat room feature. When we asked them, did the online platform actually fulfill their expectations? So they said yes, but they also thought that the physical exam actually also fulfilled their expectations. Another potential problem that can be there on an online platform was the internet speed and the technical support. So all of them were very about that fact that on a given day, they could have technical problems and internet speed could let them down. So this was an issue that all thought was a problem. Would they recommend this course to others, or would they recommend an online crash course? So 66.39% said yes, they would. So what did we learn from this survey? We thought that the online platform can be effectively used for mock exams. It is at least non-inferior to the physical exams. When you compare them in the realms of understanding the two-way communication or fluency of interaction, online mock exam holds an edge when it comes to the ability to concentrate, fluency of interaction, feeling of involvement, balancing commitments, and logistic convenience. This survey showed that online mock exam has a potential that it can give a good competition to physical mock exam. So yeah, this was the importance of online mock exam that we assessed. But now coming to surgical training, how has the surgical training changed in 2020?
Abhishek, 2 minutes.
Yes, sir. Routine cases have decreased. Residents are being shunted to COVID duties. So simulation-based training becomes extremely important. Animal models should be discouraged because of obvious issues with maintaining distance, handling. And so what can be done? What can be done is you can use homemade endo trainers like this one. This is a horizontal plank on which a smartphone is kept, and all the simulation exercises can be done. So this is how this actually looks. But how do you do it online? So there is an interesting thought that this particular device, when used a smartphone, can use a picture-in-picture mode. In the picture-in-picture mode, the mentor can, and the mentor's video can be displayed, and the trainee can follow what the mentor is trying to say. So this particular combination is very useful while training the students for the lack of actual clinical or hands-on experience. This is another model, very simple model, which people can construct at home, replicate spinoplasty situation, and in this COVID era, extremely effective. The balloon of a Foley mimics the pelvis, the catheter mimics the ureter, and the pelvic-ureteric junction can actually be dismembered and then be sewn back again. This is a comparison to real-life situation. How has the research changed? It has changed tremendously with the advent of so many webinars going on. Many research questions come in people's minds. So this was one of the research questions that we learned, or our junior colleagues learned here, that what bench studies can be done for laser. And during this COVID era, for the lack of clinical work, they started doing this particular bench studies on laser, how the stone gets fragmented, what are the temperature related issues. So these bench studies have become the order of the day. No, innovative trainings is very important. There are many training methods that need to be adopted in today's times. Like this particular example, we had a competition, intra-departmental video presentation competition, where residents presented whatever work they had done or whatever work they had assisted. And then it was evaluated online as well as in physical presence, and prize distribution was done. So this actually encouraged people to think more and probably replace the clinical part of it for some duration. So what are my take-home messages? Pandemic has brought about a sea of change in the way urological training is being carried out. Clinical work has significantly decreased, and this would definitely impact the final year resident. Online mock exam is a good replacement to conventional clinics and physical mock exams. Increase in simulation-based training is a welcome change. Increased experimental lab work will increase the research aptitude in the current generation of residents. Innovative teaching methods need to be embraced to tide over the current crisis. Thank you for a patient listening. I pass over the baton to Dr. Tushar for this question.
Thank you, Dr. Abhishek. That was a brilliant presentation, and it's actually opened our eyes to a lot of new technologies which we are not aware of, especially the telementoring part. That was brilliant. So keeping in tune with the theme of our webinar, Changing Trends in Urology 2020, we introduced an audience poll session for this webinar, and we'll have 5 audience poll questions, 1 question after each speaker finishes the talk. So the first question is, can online traditional training and webinars match the traditional teaching of MCH and DMB residents? How do you have to cast your vote? In the chat section of your screen, you'll see a vote button. This question would be live for 10 minutes till the next speaker finishes their presentation and the next question pops up. So you have 10 minutes to cast your vote, and we'll be discussing the poll results at the end of all the talks in the question and answer session. So to cast your vote, the 3 options would be available. Press the cast vote and vote on the chat section.
So shall we start with the next speaker?
Sure, sir.
So the next talk is by Dr. Rajeev TP. He's the USI Secretary, and he is going to talk on the switch over from the physical conference to the webinars. As you know, that since the COVID era has started, there is a spate of webinars which are happening all across the country. And he's going to give his experience and what he has seen in the last 4 months, and what are the plus and minus points of this physical conference versus seminars. Over to you, Rajeev.
Can you see my slides?
Yes, you can see very well. No problem.
So, good evening, sir. Good evening, other faculties and the viewers. The topic assigned to me is switch over from physical conference to webinars. Medical community basically relies on conferences, congresses, symposiums, and other live meetings with the aim to share new scientific informations and to engage with each other. This is basically to have a face-to-face connection. Personal relationships are made, and this as a foundation of human society. Basic advantages of physical conferences being eye-to-eye contact, good old handshakes, have happy hours, customized merchandise, which is a great way for companies to leave mark in the mind of attendees, strong brand association and fond memories, building authority over time. Basic disadvantages being mostly collect a sign-in sheet worth of data only. Usually these last only for 2 to 3 days before closing the doors. And congresses require renting event spaces, hiring staffs, and a lot of costs associated to travel, food, hotels, and entertainment. Now we are facing with a pandemic of COVID, and we are in the COVID era. And this is the scenario of most of the physical conferences which were scheduled for this year. So as per the WHO, in times of COVID, unlikely there should be mass gatherings. There is risk assessment for a mass gathering to reflect the cost, countries' adjustments to their public health. Event gathering may contribute to spread of COVID-19, and there is uncertain future as events are pre-planned. So basic reaction, unfortunately, it is the right thing to do. And the basic everyone says, see you next year. And there is a mixture of sense of resignation and optimism. and both the opportunities are limitless. In retrospect, do we actually need most of the meetings? Till date, we had many meetings, but when you assess from 25 to 2015, there were 30,000 plus medical meetings in the US. Can you hear me, sir?
Yes, yes.
And cancellation of medical meetings has given regular attendees the opportunity to reassess the value and to question the worth of and the effort involved in attending the meetings in person. Physical conferences do carry an ecologic footprint due to the greenhouse gas emissions. Presenter travel to and from conferences generate an important carbon footprint, and this has been significantly curtailed in the COVID times. So challenges before us in the COVID era is create short-term and long-term strategies to share information, to enable connections that are reliant on point in time and in-person gatherings. So are the conferences the most effective way to build and connect with an audience? Our basic goal, the most important thing, is to protect the health of conference goers and presenters, and at the same time to conduct a conference or congress successfully. This pandemic is coming after many years, and no such situation existed in the past 100 years. Now physical distancing has become a norm of life, and physical conference appears to be a dream in the prevailing scenario. What will be the new normal alternative? A virtual meeting or congress or webinar in order to share scientific information and to have interaction in the medical community. As in the current scenario, physical conference appears to be a rarity. So national and international conferences are being cancelled. Webinars has come the norm, and virtual conferences are being organized. So there is a significant shift towards webinars and virtual conferences. To come to the history of webinars, webinar, is a good alternative to conferences and seminars. Webinar is a blend of web and seminar. It's an event held on the internet, which is usually attended exclusively by an online audience. This was started at the end of 1980s, and by mid-1990s, web chats and instant messaging apps were developed. It was in 1995, Picturetel announced the launch of LiveShare Plus software, and the first public web conference was in May 1996. This was due to the efforts of Microsoft, that is the launch of NetMeeting, and the trademark webinar is owned by Intercall. From 2000 on, webinar service providers were GoToMeeting, GoToWebinar, ClickWebinar, MyOn Conferences, and nowadays many more are being added to this list. A webinar offers various interactive opportunities like asking questions, chatting, poll, survey, tweeting, etc., etc. The different types of webinars being training webinars, educational webinars, financial webinars, pre-recorded webinars, and live webinars as we are on today. Features of webinars are PowerPoint slides and audios and videos, real-time audio communication by use of headphones and speakers to a computer. Presentations can be recorded for later use. People are connected to the meeting, can text, chat, live for question and answers, and share screens and applications. Rules for hosting a webinar series. First is assemble an effective webinar coordination team. Their role is to assist with all the planning and logistics while ensuring the distribution of workload. Align a webinar theme to the expectation of the audience, that is mapping out the target audience needs and interests. Consider a webinar planning checklist. Main pre-webinar planning objectives and activities should be appropriately drafted and agreed upon, and share webinar organizational documents. Select team expert presenters. An advantage is the flexibility to pre-identify more than one potential domain speaker. In case of non-availability of the first potential speaker, other identified speakers can be approached. A request is also made to provide at least 3 convenient dates and slots to run through the logistics. Next is announce webinars through mailing lists and social media platform. It is key to attract a diverse and active audience for the dissemination of the webinar announcement. Allocate time for the platform orientation. Settle on a convenient and user-friendly webinar platform which is appropriate to your needs. iteratively assess and evaluate what works and what doesn't. So this is a flow chart on how you plan, carry forward, and ultimately conduct a webinar. Advantages of webinars are basically disadvantages of live conferences, which prompts us to acknowledge advantages of webinars. And webinars only need a good internet access, and you can connect with people anywhere. Participants can become a part of the meeting as well. Meeting can be conducted and transmitted from 2 to more than 1,000 people anywhere in the world, and it can be conducted on a real time and can be recorded at any point of time, and it is eco-friendly. Further, it is easy to reach target audience instantly and very efficiently. Those who otherwise may not be able to attend can still access. It is cost-effective, easy for introverts, and experienced and reputed teachers are available for a wider audience. Disadvantages are basically unexpected technical difficulties can occur at any point of time. It is dependent upon the internet facility, weather conditions as well, absence of physical interaction, and hard to gauge the level of understanding among the participants. The Urological Society of India and Indian School of Urology from late April till today had conducted nearly 25 webinars, and we have an average audience of 785. Urological Society of India has also organized a one-day youth conclave on 14th of July. It was a full-day congress spanning to around 8 hours, and we had around 1,186 viewers, and viewers from 36 countries have logged in this webinar, and it was well appreciated by one and all. There are some of the international virtual congresses being organized, as AUA recently in the month of June had organized a virtual congress. EAU has very recently organized a virtual congress, and 3 more are coming in days to come. One is Eurofair, next is SIU, followed by UAA. This is the USI calendar of events for webinars and virtual meetings from August to December end. So what do the numbers say? In March 2019, there were 60,000 webinars on our platform, and there were more than 850,000 attendees. But a year later, see, we have a significant rise in the number of webinars. It has risen to more than 5 times, that is around 300,000, and a significant increase in the number of attendees. That is 547% increase, and the revenue is to the tune of $18,000. Physical versus virtual meetings. Virtual meetings has many advantages over physical meetings as cited here, like cost effectiveness with flexibility, mass data, and only basic little bit where it varies is in the networking. So virtual meetings, pros and cons. Pros of virtual meetings are
Rajeev, 2 minutes.
Yes, sir. Real-time engagement, captive experiences as it is live, can engage a wider audience and international collaborations. But the cons are time zone conflict for speakers and viewers, less effective than in-person networking, and poor revenue stream. So virtual or in-person, what matters is being present, engaging audience, bringing together policy makers, which supports urologists in COVID times. What next is in-person conferences will be difficult for the next few years, it appears to be. 2 main reasons being economic hardships experienced in the wake of the pandemic, high risk of infection associated with travel and mass gatherings. So whether medical meetings may be changed forever, medical meetings known to attract large gatherings of diverse groups of physicians, nurses, and allied health professionals, which gives significant opportunities for traveling, mingling, and socializing, may take some time to return back. What is the food for thought? The situation we find ourselves in has given us the opportunity to reevaluate ourselves, the needs and impact of attending these gatherings, including the environmental consequences. No matter what may be, the show should go on. So to conclude, with no sight of the battle against COVID coming to an end, webinars are the best alternative to a physical conference. Webinars may be the future of conferences or meetings. It is eco-friendly, has got a wider accessibility, cost-effective vis-a-vis physical conference. May say a new normal for future events. I am here to stay for the days to come.
Thank you for your patient hearing.
Thank you, Rajeev sir. That was an exhaustive presentation of all the webinars. I was just wondering what would we have done if it was not for webinars in this time of COVID? How disconnected would we all have been? Can we have the poll question, sir? The poll question number 2. Rajeev sir, the last slide of your presentation. The polling for the first question would stop now, and we'll start recording the responses for the second question. I'll read out the second question. The second question reads, what is the biggest drawback you feel for virtual conferences? Your options would be A, lack of academic fervor, B, unable to meet old friends and colleagues, and C would be unable to visit the exhibition area and learn about the latest developments in technologies and armamentarium. So you have 3 options. The question must be available on your screen. The vote button is there on the chat box. Cast your votes. This question would be live for the next 10 minutes. Sabnis, any comments?
No, I think it was a very nice presentation, and he has made out lots of points. And I'm sure in the last half an hour in the question answer session, we'll throw some questions to him.
Sure, sir.
So thank you, Raju, for that fantastic, exhaustive talk on the different changing trends in the conferences. We move on to the next talk, which is on the endourology practice. What has changed in the endourology practice? And I'm going to invite Dr. Amelia for that. Please, Dr. Amelia, please go ahead. Dr. Amelia?
Still, sorry, I was mute. Hello, nice to meet you.
Okay.
I am Amelia Pietropaolo, and thank you very much for inviting me to this very interesting webinar. Thank you for to the iTrue group. So this is my screen. Can you tell me if you can see?
Yes, we can very well see and hear.
Perfect. Thank you very much. So we're going to discuss about change in endourology practice. And as I said before, my name is Amelia Pietropaolo. I work in Southampton in United Kingdom, and I'm an associate specialist in endourology. And when we were asking what would have happened in 2020, no one thought that a pandemic, COVID-19, would have changed our way of seeing the world. But with this, we had to change a lot of other things, and thankfully, a lot of innovation came as well. So people started to create and innovate with new ideas in every field. For example, creating new ways of overcoming social distances with hugging techniques to hug their families, or using common snorkeling masks that have been transformed in CPAP in intensive care units. So humanity had to reinvent themselves, and we have started to work in a different ways, or the art and creativity had different focus, in particular in healthcare and social care. And communication as well has changed, in particular in the medical field. So surgeons in particular had to learn a new way of communicating despite the difficult PPE effect on communication and listening to each other. So thankfully, from the urology point of view, the European Association of Urology helped us with guidelines and recommendation to understand which would be the next standard of care in this difficult pandemic time. And for example, the triaging of the surgeries have been started, in particular to understand which type of surgery had to go ahead despite pandemic disease. And so the emergency surgery had to go ahead together with all the procedures that would have, if not done, would have compromised the survival of the patient. But everything else was postponed or delayed for months. And this happens also in endourology, but some pathologies, for example, infected obstructing stones, had been considered emergencies, and they needed decompression regardless of the problems with general anesthesia and the pandemic disease. And also a patient with long-term stones and stents, they've been considered their priorities anyway, but all the other non-obstructing stones, for example, they have waited and the procedure has been postponed up to 6 to 12 weeks. So many papers have been published in this time, as we will see, and some of them have been considered to create these guidelines and recommendation. And these have included different countries, because being a pandemic, we can see that every country has been involved in this, and everyone trying to find a solution for this in their own country. Unfortunately, the real problem is that the high mortality is expected in patients who have COVID-19 in their post-operative period, and also there is a risk for healthcare workers following intubation for the droplets that can affect and contaminate the air in the operating theaters. This is why we can't go back to normal life and to how we were working before, and we had to go forward and to look at a different future. This is why telemedicine has been introduced. So a lot of consultation have been happening online. And this is one of the most important papers on the field, written by my friend Silvia Proietti, who is describing how in Italy, which was one of the most affected areas in Europe, in particular north of Italy, how they have managed to continue to treat safely patients who had emergency pathologies. And also in UK, we had to use the same technique and the same procedures. And this is what we've done in our hospital. So we have some clinic appointments or outpatients reviews have been cancelled by the hospital or by the patient for fear of contamination. But most of them, they've been maintained and they've been rearranged with a telephone or virtual consultation. This allowed us to continue to see a lot of patients during this time. We have to say that this was we learned this from a previous experience of a virtual clinic that we were already carrying out in the over the last 6 years in our virtual stone clinic. So we've used to do it for years, and patients have demonstrated to be very keen to be followed up in a telephone clinic, and it's a very cost-effective for the hospital as well, and can be an example for the future. Also, we've seen a lot of of people who had obstructing stones to have acute hot lithotripsy rather than general anesthesia procedures. This was very effective and has been very effective as a treatment, in particular because it prevents the patient to undergo a general anesthesia, for example, ureteroscopy or stent insertion. Therefore, it's a quicker hospital stay, and you can the follow-up can be done via phone or with remote imaging. And also we've been the regional referral for the south of England for this type of patients. And also the lithotripsy clearly doesn't require any general anesthesia, which is good in a COVID time, and can be easier and more comfortable for the patient if we, for example, we use other distractions, for example, light or sound, and that's what we normally do in our clinic. Other innovation that we have started in the endourology field and worldwide is to try to do stent removal with disposable scopes. And this has allowed the patient to just come for a quick clinic consultation that allows the patient to prevent a hospital stay, and is just an outpatient procedure so that the patient can go immediately home after the stent removal, reducing the hospital stay. And is also cost effective for the hospital to have disposable, flexible ureteroscopes to remove the stents rather than reusable one. Also, a lot of patients have had local anesthesia or spinal anesthesia procedures, which has reduced the general anesthesia operations. And we have looked at the ureteroscopies and the stone procedures done under local anesthesia, which is very important, in particular in this, to prevent, as we said, the intubation of our patient and reduce the mortality after surgery. And there are a lot of papers describing that, with including the protocol of local regional anesthesia. In terms of reducing the operating time and the hospital stay, there are a lot of innovation that we can use. They've been used in the last years as well, but clearly now we need to concentrate to use them as much as we can to reduce the patient hospital staying and improve the outcomes. So, for example, high power laser, including MOSE technique for stone treatment, can guarantee the formation of fine fragments and to increase the stone clearance and reduce the recurrence rate. So the patient will need less procedure and less general anesthesia procedure and less admission to the hospital for recurrence of renal colic. And with the high power laser, we use normally this pop dusting technique, which has allowed the patient to have a better stone-free rate. And this can be used also in pediatric cases, stone cases, which is an innovation, because is to show that the high power laser is safe also in pediatric patients. A new innovation of the new technology is the thulium fiber laser. This is a new technology for the laser and is a completely different type of laser that has a very high frequency, a long pulse duration, and allows to create very, very fine dust and very much quicker compared to the Holmium laser, which was the one I was talking about before. This is the last, the new arrived on the in the market, and allows to have a much better stone-free rate in a quicker time. And despite the technology is very different, the machine is very light and easy to use. So we should try to get this as well in our daily practice to have a better outcome in our stone surgery. Another new technique and technology that has been introduced to improve the stone-free rate is the stone aspiration device. This facilitates the aspiration of the stones and reduces the time of stone retrieval with the basket. So we have to say we have everything in our lives have changed, but it's important that we change as well, because we still have the duty to deliver efficient and safe and the urology treatment for our patients. And it's true that thanks to these webinars, as we said so far, our lives are very, very, very connected, even more than before. So thank you very much for your attention and your invitation. And this is the next poll question.
Thank you very much, Dr. Amelia, for giving us an exhaustive overview of endourology practices in the United Kingdom. One slide which I particularly found interesting was the sign language that is used during the surgery. That was really interesting. We will move on to the next poll question. Should routine RIRS, PCNL, and URS continue in the times of COVID in our country in particular? Option 1 is yes, they can continue, and option B is no, they should be deferred. The polling starts now. This question will be live for the next 10 minutes. Sabnis, over to you.
Yeah, I think it was a fantastic presentation, and you have given real overview as to what has changed in endourology and what should we adopt. There are a few questions which we will ask you at the end of the session. But I now invite Dr. Rajeev Kumar for his talk on the surge in publication. As we have seen since the COVID era has started, there are huge amount of publications which have come in. And I was just searching, putting in PubMed COVID-19. And there are 33,000 articles which are published in PubMed in last 3-4 months since the COVID has started. So this is a kind of surge which is coming up, not only from the COVID related, but even the other related. So I am going to ask Rajeev Kumar to give the overview as what has changed in this COVID-19 with respect to publications. Over to you, Dr. Rajeev Kumar.
Thank you, Dr. Sabnis. Thank you for inviting me to be a part of this seminar. It's a pleasure to be here. I hope you can hear me and see my screen.
Yes, very well.
Perfect. Thank you. So we're talking about COVID-19 and publications. And what you've just said about 33,000 publications on PubMed is so absolutely true that it is not just on PubMed, it's all over the place. And just let's look at the publication cycle. What is a publication? A publication begins by creation of an idea, which you then research, you evaluate it, you write it because somebody needs it, and thereafter you bring it into the public domain. That's a standard publication cycle. Everyone who's published an article knows that it looks very simple to draw a cycle like this, but it's extremely painful to actually run through this entire cycle. And this is precisely what the path looks like. It's you who've turned bald with all the work that you've done over the last 2 years or so to gather your data. But there are a bunch of people who are preventing you from going and getting that publication. This is standard. This is a picture I show practically every other month on one or the other webinars or talks that I do because it's absolutely the truth. On the other hand, what has changed for the new normal now is that the doors are open. All you need to do is show that you have an idea. You need to have that light bulb in your brain. You show that light bulb to the editor and to the reviewers, and the doors open up for you. That somehow seems to be the new normal. So let's go back to thinking for a minute about why has all this changed. This gentleman that you see here is Alexander Fleming, working in his lab on penicillin. He became important because we needed answers. We needed something to treat infections, and therefore when he discovered penicillin, it was big news. As of today, in the world of pandemics and coronavirus, we are going through exactly the same cycle. This virus came and hit us. We had no idea what it was. We had no idea how to diagnose it, how to treat it. And therefore, we were searching for answers. It's almost as if we had gone back 300 years in the cycle of medicine where we really knew nothing. And therefore, we were searching for answers. And therefore, the good was that all of a sudden, there was this huge amount of research that was being done at every single site in the world. And that research came out in a torrent. Now, this picture that I've taken actually is from an article which doesn't say good things about this torrent. But nonetheless, to me, it epitomized what exactly happened. Now, a torrent, for many people who are savvy with the net, also understand that torrents are associated with downloading stuff that you're not supposed to download. So it's a means of getting away. And I thought the pun on the word torrent sounded good. So you had a lot of new stuff that was coming out into the market, into the literature, and it was fulfilling a need. We needed those answers. Does remdesivir work? Does HCQS work? Do we need to give plasma? Does TCZ work? Lots of questions. And therefore, the flurry of articles was welcome. And that's something that is symbolized in hard facts when you look at these two diagrams. Now, I understand diagrams and text is very difficult to see on webinars when you're looking at a 13-inch screen. Therefore, I try to minimize text, but nonetheless, there are some diagrams to show. So if you look at the upper picture, it shows you the growth of cases in COVID. And using the same dates, what you see on the lower chart is the growth in the number of publications. You could virtually superimpose the two charts. And as of May 2020, there were 16,000 publications on COVID alone, not just the overall publications, COVID alone. And this is now more than 2 months ago. And what happened at the IJU? The IJU had a very similar phenomena. We had a 3-time increase in the number of submissions in the 3 months that we were talking about. And the increase was on both COVID and non-COVID publications. So on COVID, we got a lot of opinion. We got tons of surveys and opinion polls. Virtually everybody was doing a survey and wanted it published. In the non-COVID articles, we had a lot of people pulling out data that probably was sitting around in their offices or in their desktops, and they now had time because they couldn't operate. So they were rehashing and digging out data. So is this all good? So then let's look at what has changed to bring about so many publications in such a short time. Again, let's look at the graph on the right-hand side. Like a typical bell curve, this is the normal time it takes to publish an article, a median of about 115 days to get it into publication. Look at what happened to COVID. This is just the COVID graph, and that 115 dropped down 10 times to a median of only about 15 in the COVID era. Look also at non-COVID during the COVID era. That's this graph. Now you would assume that COVID will get published quickly, but why would non-COVID get published quickly? Somehow, even the non-COVID is getting published much quicker at just about 35 days. So it seems that in COVID, people have no other work to do, and therefore they're happier to review, they're happier to rush it through the publication system, and everything is getting published quicker. So is this all still good? We are shortening the cycle. And if you look at, these are the number of journals which have shortened. Almost every journal has shortened the cycle. All the lines above the baseline mean the degree of shortening, and the shortening has gone up to 100%. And at the times that it took time to review, time for the editor to take a decision, everything has shortened virtually by 100%. So is this all good? You're all getting your answers quicker. Yes or no, it's getting published quicker. Should make everybody happy. But then we come to the ugly. You can't have all the cake and not get poison that's stuffed in with it. Then comes the issues of retractions. Why do retractions happen? Why do the publications get into a trouble? And the biggest problem that the whole world came to see were these two prime publications, The Lancet and the New England Journal of Medicine, the Holy Grail, and unfortunately, all three doctors of Indian origin. And this is what brings you the question, were we just being too quick? Were we overlooking the checks and balances that exist within the system simply because we wanted to get it out quickly? And for once, people agreed that peer review is good. This bunch of people who we all love to hate. I mean, it's every day that I get some comment, some phone call, some message. Who is he to decide on my article? You are picking up the wrong reviewers. These reviewers hate my article. Why are you giving my article to them to review? Reviewers don't do anything. They can't do a publication themselves, and they're stopping me. There are tons of things that are said about peer review. But this is the time we realize peer review is good. Do editors get it right? Because at the end of the day, it's the editor who's taking a decision. So we did a little bit of an in-house research to see, do editors actually take the right decision? Now, editors are also reviewers. So what we decided was, we'll look at the manuscripts where we are reviewers and see whether the final editor's decision matched our opinion as a reviewer. And interestingly, when editors are reviewers, their opinions match the final decision on the article 81% of the times, compared to 67% for other reviewers. Even more interestingly, on every occasion where our opinion as a reviewer did not match the final decision of the editor, we were almost always more favorable to the author. In all except one, where we said reject, but the final decision was accept, we had always said revise or accept, where even if the decision finally was reject. So we're actually being kind. We are not being too harsh. So finally, this is the last slide. What has changed in the COVID era? We began publications in order to benefit mankind. That's what we thought about in early March when we were looking for publications on COVID, because we needed answers to benefit mankind. Unfortunately, from the good that publications do, we very rapidly deteriorated to the bad, where people used the opportunity that the gates of the NEJM, the gates of the Lancet seemed to be open, that they managed to get in stuff which possibly did not merit going in. And therefore, we come down to what is the bottom line in publications. The bottom line always will be honesty. There are very few studies which would get checked. You just don't have the time to go back and check the data. But when something as large as Sergi Sphere puts out thousands of patients of data, even a blind man can see that there is a problem. And therefore, you come down to your honesty. What I've said today can actually be found in the editorial that we've written for the most recent issue of the Indian Journal of Urology. The journal is online. It's been online since the 1st of July. What I have said is exactly what's written in there, that this current pandemic has given us practically a webinar on journalology. It's gone from the good to the bad and to the ugly and everything else in between. Thank you once again for the opportunity, and I hand it back to you, Tushar, for the audience poll.
Thank you, sir. I just hope it's gone back from good to bad to the ugly. It comes back to being good again soon, sir. Thank you. Can we have the audience poll question, sir? Yeah. So the fourth audience poll question is, what do you think is the real reason for a surge in urological manuscript submissions since March, that is since the beginning of the COVID? First option is zeal to contribute to COVID research in urology. The second option is opportunity to use COVID as a context to publish a paper. C, spare time to dig up existing data and write the paper. Or D, fear of missing out or because of peer pressure. We've had a lot of questions from the audience directed towards you, sir, for the publication. We'll save that for the question and answer round. Over to you, Sabnis, sir.
Thank you very much. It was a very nice overview, and you really touched upon almost every aspect. In fact, some of the questions which I had in mind, you already answered to them. But there are a few questions which are left out, and I'm going to take those questions at the end of the all the talks, and then we'll ask your opinion for that. So with this, now we go to the next talk, that is by Dr. Gagan Gautam, and he's going to talk on the COVID-19, how it has changed the uro-oncology practice. As you know, every field, whether it is endourology, whether it is general urology, whatever, every field has changed, and he's going to give the overview as to what has changed in uro-oncology. So over to you, Dr. Gagan.
Thank you so much, sir. Are you able to see my screen and hear my voice?
Very well.
Thank you so much, sir. It's indeed an honor and a pleasure to be a part of this very unconventional webinar with an unconventional topic. And Dr. Rajeev Kumar is my teacher, and he's always a very hard act to follow after he's given his presentation. But I'm going to do my best and try to come up with something useful. First of all, I would like to thank two young and dynamic uro-oncologists in India, and one of them is a moderator, and that's not the reason why I'm being nice to him. He was one of the first ones to publish an article in which a few of us were also there, but he conceptualized the article, wrote it, did all the hard work, and published on uro-oncology in the times of COVID in the Indian Journal of Cancer. And the second dynamic young uro-oncologist is our current fellow. He is Dr. Danny Darlington. He recently wrote this review article in the Indian Journal of Urology in the recent edition. And a lot of what I'm going to actually say is derived from whatever I've learned by reading these two articles. In fact, I've picked up figures and put them here, and they've really made my job easy and simple. This is my disclosure. So as we know, what is the current situation? Well, they say that only the wisest and the stupidest of men never change. And most of us, including myself, would be somewhere between these two extremes. So that means that we probably have to change with the times, and whatever is happening right now is giving enough impetus for us to change. There's no doubt that this particular pandemic has taken us by surprise. We never expected it. And as a result, now there are more than 15 million confirmed cases in the world. There are more than 500,000 people have died, and things are not looking very rosy in India as well. More than 1.2 million infected, 30,000 deaths. And there seems to be no end to the pandemic in the near future. Now, but within India, there are different, India is probably a mixture of 1,000 different geographical areas. And within India, there will be places where the pandemic is already over the peak, and most others are actually still rising. So Delhi, in fact, is coming down, the active cases, but places like Maharashtra, Tamil Nadu, Karnataka, which had initially, especially Karnataka and Kerala, which had initially done pretty well, are now heading upwards, and there is no peak anytime soon. So before I actually get into the uro-oncology aspect of the discussion, I'd like to make a few disclaimers. Firstly, we have, and Dr. Amelia really nicely, eloquently, alluded to that, because, and it told us about the recommendations for being able to delay cases, for whether we should delay for 3 months, 6 months. Even in uro-oncology, we are able to delay cases without much harm to patients, especially if they don't really have aggressive disease. But we don't really know when it will end. So how much are you going to delay cases? Is 3 months okay? Well, 3 months back, we were saying we'll delay cases for 3 months. Now, another 3 months, another 3 months. So when will this end? We don't really know. So we have to make some provisions for prioritizing and not delaying cases indefinitely. The second part is that we are going to talk about triaging of cases. And that has also been one of the recommendations by almost every publication, including the 2 publications that I alluded to right now. But the question is, where are the patients? Now, we may sit in our hospitals, especially the private hospitals, and saying that, okay, we are going to triage cases. The fact of the matter is that the patients are simply not coming to the hospital. And that is the situation in most of the hospitals in our country at present. I don't know whether things are any different in government hospitals. I don't think there are. But what I believe is that patients are actually self-triaging. Only if they really, really have to go to the hospital, they're going to go to the hospital. Otherwise, patients are simply scared of coming in contact with any healthcare worker. The fear of coronavirus or the fear of COVID is practically bigger than the impact COVID has had. And this can actually have disastrous consequences, especially for those uro-oncological patients who need immediate or early treatment because of their malignancies. So as a result, I think the wheel has turned a full circle. Initially, we were saying we won't operate you, go back, don't come for the next 3 months, we'll delay cases. But now cancer societies all over the world and within India and even institutions are actually running campaigns on social media saying that cancer won't wait, come to the hospital, get diagnosed, get treated. So I think there is some kind of a disconnect between us trying to triage patients and the patients themselves, not coming to the hospital for any triaging, so to speak. Also, a lot of things that we are going to say about managing uro-oncology patients, or for that matter, any patients in this era, is based on assumptions and presumptions. There is hardly any level 1 evidence available with regards to the impact of treatment of cancer in this kind of a situation. The only level 1 evidence that we have is on the base for trials which have looked at the effectivity of one particular type of medication, say for example dexamethasone or remdesivir for the COVID disease itself. But what about the other malignancies and the other issues? We don't have much to be categorical about. At the same time, I don't think all is lost. I think there are signs of hope. Our capital, Delhi, has decreased its maximum active patients from around 30,000 down to now 13,000 something yesterday. So it does seem that we are kind of going down on the curve here, but India is a large country. There are many areas that we have to control before we say that we are going to be able to take care of this in the future. At the same time, because of better management, better ability of the clinicians and the physicians to diagnose and treat COVID disease, the fatality rate in India has come down significantly. Now, latest data is about 2.3% fatality in India. And we appear to be quite healthy when we compare this with what is happening in the Western countries. And do we have some innate immunity? Have we been exposed to so many viruses while growing up that this virus is not causing trouble to us? Is it BCG? Is it the good effective measures taken by the healthcare providers? I don't know, but the fatality rate in India is pretty low as compared to the other countries. Also, we have been able to ramp up production of personal protective equipment. Initially, there was a lot of hue and cry about the lack of availability of PPE, but I think it's now much better. Even the defense services, and this is the Indian Navy, have stepped in to design PPE equipment for medical health workers. And this is now, I think, present well in most of the places. Similarly, newer hospitals have come up, newer COVID care centers have come up, where isolation of COVID patients has become easier from the rest of the society. And of course, there's exciting data about new vaccines which are coming up. There are already 2 clinical trials running in India. And of course, this Oxford vaccine, which published its initial results in Lancet, is something that may be something for the future with the manufacturing hub planned to be in India. So all this should reassure patients that if they require care, they will get it. Now, coming to the uro-oncology itself, if you look at in a broad sense, what has COVID or the era of COVID done in terms of changing the way that we feel, and how can we implement it in the treatment of uro-oncological patients? I think one of the very clear thing that comes about is that active surveillance is again very in the focus. And obviously we know about active surveillance for prostate cancer, but even small bladder tumors, which are TA low grade, they can be safely actively monitored over a period of time. And if you look at this particular publication, out of this about 131 low grade TA patients, there even for active surveillance up to 36 months in certain situations, none of these patients actually developed muscle invasive disease. And most of these patients remained TA low grade. There were about 10%, 15% patients who did become T1, but they were also easily managed subsequently, and there was no metastasis or T2 disease in any of these patients. So a lot of bladder cancer, especially those patients who've had initial low-grade TA disease and have been on subsequent cystoscopic follow-ups, you don't need to really take them to GA right now. You can observe these lesions and see them after about 3 and 6 months, and then take a call whether you want to do a TURBT in these patients or not. Also for kidney cancer, even if you look at the latest NCCN guidelines, the stage T1A disease, one of the equally important recommendations is active surveillance. So T1A active surveillance, you would expect the tumor not to grow beyond the speed of about 0.2 or 0.3 centimeters in a year. You can monitor these patients. Their chances of metastasis are pretty low. If the tumor is less than 4 centimeters in size, the chances that there will be a metastasis is less than 5%. And at the same time, even T1B tumors can be observed in select patients, but these are typically those patients who have got limited life expectancy and multiple comorbidities. At the very least, you can look at active surveillance for these patients. For prostate cancer, we already know low-risk prostate cancer, active surveillance is the treatment of choice. However, even for favorable intermediate risk group, Gleason 3+4s, grade group 2s, T2Bs, even those with a PSA, say more than 10, you can consider active surveillance, and that's what is recommended even by the NCCN guidelines. However, especially in India, we need to take active surveillance with a pinch of salt. And this is, again, an article that we published in Indian Journal of Urology. And thank you, Dr. Rajeev Kumar, for actually accepting it in the rush of all the COVID publications that were coming in. This was published a month back, and we looked at our own data of 500 plus robotic prostatectomies over the last 6 years. And we found that only 8.1% of these patients actually had fulfilled the criteria for active surveillance on the basis of a low risk DMECO classification. That means about 92% of the patients that we are operating in India are actually intermediate or high risk. In fact, more than 50% are high risk. And even in these 46 patients, or 8.1% of the total patients that we operated, there was an upgradation rate of 50% and an upstaging in nearly 20% of patients. So some of these were even seminal vesicle positive. So a lot of times the biology of the patients that we get in India may be different from that in the West. So we should not blindly apply the guidelines from there. We need to have our own data, and we need to have our own set of guidelines regarding the treatment of patients, even for active surveillance. What about perioperative chemotherapy? One of the initial studies published in Lancet Oncology actually found that the chances of significant morbidity and mortality in patients with cancer and COVID was much higher in patients as compared to patients who did not have a history of cancer. And that is pretty intuitive, because any kind of cancer or the treatment of the same is going to bring down your immunity and probably make you more susceptible to the COVID infection. However, amongst the patients who have cancer, so this is a Lancet study, amongst the patients who have cancer, the probability of mortality is not higher whether or not you have given any chemotherapy within the last 4 weeks. So, but if you look at the overall picture, you would find that about 28% of patients with a diagnosis of cancer and COVID succumb to the disease. So this 28% mortality is extremely high. So we need to make sure that these patients who are immunocompromised get only the treatment that they really require. So for example, if you consider patients with metastatic disease, obviously they need chemotherapy and they need to be given chemotherapy with all the precautions. But if you, for example, take a gentleman or a lady with a T2 bladder cancer with no evidence of extravesical extension, clear lymph nodes, would you take this patient up for a neoadjuvant chemotherapy? Well, that's a question of debate. On the other hand, even in this circumstance, if you have a tumor which is going outside the bladder or there is an involvement of lymph nodes, then obviously the risk-benefit ratio is in favor of giving neoadjuvant chemotherapy. So perioperative chemotherapy, there is a question mark and needs to be decided on an individual basis. What about surgery versus radiation therapy? Now, we don't really know the answer to this question. If a patient has high-risk prostate cancer, are you going to bring him to the hospital for 30 minutes every day to give him radiation therapy for 1.5 to 2 months? Or are you going to admit him, give him GA, do a robotic prostatectomy and discharge the next day? The answer is not available in the literature. But in my personal, albeit biased opinion, I do believe that doing surgery for a high-risk prostate cancer and going in for a multimodality treatment where you may defer the treatment for radiation or any additional treatment by about 6 months or 9 months, if at all it is required, makes more sense rather than bringing the patient again and again to the healthcare system and exposing him to radiation therapy. But the jury is still out on this and different opinions will be there, I'm sure. So now I will wrap up by going into a little bit specific discussion about the 3 most common malignancies that we see in uro-oncology. And these diagrams I've picked up directly from Danny's paper, which was published in the Indian Journal of Urology a few days back. This is, what about renal cell carcinoma? You stage it. If you find a T1 tumor, you can defer treatment, put the patient on active surveillance. T1A, definitely you can put on active surveillance. T1B, plus minus. T2, T3, T4, high priority for surgery. I don't think they should wait. What about those with metastasis? There is now increasing evidence that cytoreductive nephrectomy may not be an ideal treatment option for most patients with minimal or asymptomatic disease. Cytoreductive nephrectomy should be avoided. These patients should go in for a TKI or further treatment over time. What about bladder cancer? Initial investigations remain the same. Small TA low-grade tumor, well, you can think about waiting, but you won't really know whether it's a TA tumor until you actually remove it to be sure. But if you are in a follow-up, you can observe small lesions. If you see multiple tumors or suspect a high-grade pathology, do a TURBT, find a muscle-invasive disease, then you have to decide between radical cystectomy versus bladder preservation protocol. I would rather go for radical cystectomy and defer bladder preservation protocol because of the repeated contact with the radiation and the chemotherapy systems in the healthcare environment. Neoadjuvant chemotherapy, you need to individualize treatment based on whether it's a T2 for sure or whether it's beyond T2, and then of course neoadjuvant chemotherapy makes sense. Metastatic disease management is pretty standard. BCG induction, I think, is important for high-risk disease, but maintenance BCG is something that you can decide on a case-to-case basis. And hopefully by the time for maintenance BCG comes, we will be through this trouble. Prostate cancer, well, there's not much controversy about low and intermediate risk disease. You can easily defer treatment by 6 months, no harm will be done to the patient. But for high-risk prostate cancer, again, the controversy between radiation and radical prostatectomy. If good facilities are available for robotic surgery, my personal preference would be to take these patients up for surgery rather than radiation therapy. Metastatic CA prostate, hormonal therapy is easy to implement. You can give a 6-month LHRH analog if you want. Docetaxel, probably avoidable in this situation, can easily be followed up later after 3 or 6 months after the initial response with androgen deprivation therapy. And finally, before I conclude, the controversy about whether we can do minimally invasive surgery or robotic surgery in this situation. Now, the size of a COVID particle is only 0.1 micron. And when I saw this, and I actually read it just a couple of days back, I got a little bit scared because if you look at the N95 mask, its filter is 0.3 microns. So I thought, oh, why are you using N95 masks if the virus can go right through? Well, I found an answer to that. It's because the virus itself doesn't actually go through the mask. It's the droplets, the aerosol droplets that are created, which are about 5 microns or less. So N95 works well in most of the situations like that. But when you're talking about aerosol generation in surgery, it may be a different ball game. And the device that we use is the air seal system. With the air seal system, you can actually filter, and using the smoke evacuation mode, you can filter particles up to 0.01 microns with almost 100% efficiency and keep the operating environment safe. In fact, I do believe, and according to...
Can you just conclude?
Last slide, sir. So there may be certain advantages of robotic surgery in this situation. When you're doing open surgery, there may be a dispersion of aerosol. There is more exposure. There is more blood loss. There are larger number of instruments used, a heavier blood contamination. Hospital stays longer. As a result, open surgery may be less safe in most circumstances as compared to robotic surgery. I would like to conclude by this, that if high-level precautions are being taken, including sufficient PPE and prevention of carbon dioxide aerosol, then robotic surgery may offer a better alternative as compared to open surgery. Finally, to the poll question, but before I come to it, take-home messages: one size will not fit all. You will have to decide management on the basis of what is the geographical peculiarities of the disease in your particular area and the facilities in your institution. There is light at the end of the tunnel, especially with the vaccine coming about. Active surveillance should be encouraged for all types of urological malignancies if it is feasible, if it's early and indolent. Think twice about perioperative chemotherapy. And MIS with precautions may trump, and no pun intended here, radiation therapy and open surgery. Over to Tushar for the poll question.
Thanks a lot, sir, for that rockstar presentation. You actually got us scared for a minute when you said the N95 doesn't screen the coronavirus. We all were stunned for a minute. Going on to the fifth poll question. Do you feel confident in triaging various urological malignancies for treatment in the light of the ongoing pandemic? Option 1 is yes, I'm confident. Option B is have a rough idea. C, no, I'm not aware. And the last option is I don't feel the need to triage. So the polling is open for this question. The polling will be open for the next 5 minutes because then we'll be taking the results for the poll question. Before I hand over to Dr. Sabnis for the question answer session, I would like to bring in Dr. Zeeshan. He is an associate professor of urology at KMC Manipal and the secretary for ITRU. And I just had one question for him, but before I pose that question to him, I would like our viewers to know that he is an actual corona warrior. The irony was that one day before the webinar, he tested positive for COVID. But as you say, the show must go on. So he's here sitting with us. So Dr. Zeeshan, just one question to you, and then we move to the question and answer session. What do you think is the future of urology in India in light of this COVID-19 pandemic? How do you see it unfolding?
Thank you, Tushar. Thank you for, even letting people know that I'm positive so that they can come for my plasma. Yeah, about your question, we are one of the most advanced subspecialties. We are embracing latest advancements and innovations. So I think there will be more of curated and customized treatment in future when it comes to treatment. And also we are looking into newer way of communicating with our patients using telemedicine and even training by telementoring. I think these are the other new dimensions which we have to look into in future. And when it comes to training for the postgraduates, everybody is well aware right now about various subspecialties. Even our USI is taking so many webinars telling them what are the opportunities, what they have. So I think a lot of people will go in for subspecialties and be focused into their own field of interest. And about conferences, we are going to have a lot of webinars and more of hopefully, in physical and hybrid conferences in future. Yeah, thank you.
Thanks a lot. We have to admit the corona has brought in a lot of new innovations and it has brought us all closer. Yeah, sure. So I think, Sabnis, if you permit, we can move on to the question answer session with the poll questions.
Is that give us the result of the first.
Yeah,
we'll ask some questions related to that. Then you give the second poll result. Something like that will go ahead.
Sure, sir. I'll ask her back. And Rahul, are you ready with the first poll results? Can you hear me, Rahul?
Yes, sir. I'm ready. I was on mute. Sorry.
Yeah. So the results for the first poll question. Can we have the question 2 and the answers? Dr. Abhishek, are you there? I think
Yeah, I'm
most of the
pretty
questions
much.
would be directed. Yeah, sure, great.
I'm pretty much there.
Yeah, so this was the first poll question. Can online training and webinars match the traditional teaching for MCH and DNB residents? I think we had around 60 responses. The results were no. 59% of the people said no, 33% of the people said yes, and 8% of the people said can't say.
All right. So, I think that's a very eye-opening poll result. And at present, the poll is being participated by 322 people who have logged in just now. So it's across the country, across the people are watching, and they are participating in the poll. Abhishek, I want to put this question to you, that you said lots of benefits of online training, online classes which you have organized. But the poll seems to be saying that the physical is much better than the. So what do you think are the main reasons for that? Why still people are hesitant, or they are still not happy with the online training and teaching? What do you think is the main reasons?
Sir, what I believe is that the impact that a webinar or an online teaching program creates, one drawback is that the impact is momentary. It does not last over a period of time. Like when you go into a physical classroom or a physical meeting, there are a lot of associated memories or associated experiences that you carry back home, which probably does not happen on the online platform. I think that is the one major drawback. But still, I believe that they are not mutually exclusive. They are interlinked things. And now we have taken 2 steps forward in the webinar or the online platform. Maybe we go 1 step backward, but still it will be a part of our system.
Abhishek, I want to ask one question. One question is that, do you think that when people attend the classroom on the virtual platform, as against to a mock exam in the real situation, do you think that participants are as serious in the mock exam as they are in the physical platform? Because when you are in the classroom, you are committed, your focus is only on the classes which are going on, whereas here you are sitting at your home and by the way you are just listening to classes. Is the seriousness issue in virtual classroom? What do you think?
Sir, I don't think the commitment of the candidate is an issue, because the candidates which actually attend this program are exam going in 3 months, and they take every bit of it seriously. Not everybody has the exposure and opportunity to attend a clinic on a daily basis. So more the number of clinics, the better these batches prepared. We are faculty in our institute, and you and me both have experienced that the way this batch is prepared, the earlier batches were not. Right. So I would again say that they are complementary. They are not mutually exclusive. It may probably not replace it, but it is complementary.
Right. I think that's a very, very important point which you have brought in, that often we have seen, and this has been deliberated in various examiners meeting, that the training is not same across the country. There are certain institutes which give good training. There are certain institutes which are not offering that good training. And this webinars and virtual classrooms, I think it will make the level playing for everyone. Those who are at not proper exposure, I think they also are likely to get the adequate exposure. They are likely to face the examiners in the same manner, which otherwise they would have not had. So I think those benefits definitely are there. So thank you, Abhishek, for that excellent overview and answering some of those questions. Tushar, can you go for the next poll result?
Can I to Abhishek, sir?
Yeah, please go ahead.
One more major important thing which is happening right now is we are getting a lot of recorded material, which before we never used to have. Yeah. Now these people, more than attending webinars, they log in, they try to search material which is relevant, and they get back to that, which never used to happen before. This is one advantage of the present year.
Yeah, I totally agree, Zeeshan. I think that is a major advantage. Why only for residents, even for you and me, who are still climbing the ladder.
Yeah, so for those people who miss when it is actually live going on, people can see the recorded version at their leisure when they are seeing. But one flip side of that is that when you think that I will see the recording afterwards, it generally never happens. You tend to become lazy and then say, okay, and then after a few days you forget what you wanted to listen. So that also a flip side is there. If you are there live, okay, yes, you have heard. But after that, it never comes in. So that also is there.
So true.
Okay, Tushar, for the next.
Sure, sir. Rahul, can we have the second question? The results are ready for that. Yeah. So coming to Dr. Rajeev TP sir's talk, switching over to virtual conferences from physical conferences. The poll question was, what is the biggest drawback you feel of virtual conferences? So the highest number, 43%, were answered as unable to visit the exhibition area and learn about the latest developments in technologies and armamentarium. That was 43%. The second spot went to unable to meet old friends and colleagues. And the third, 28%, was lack of academic fervor.
Yeah, I
So
think this poll also interprets almost everything what is there in everybody's mind. That when we attend the conference, it's not just the academics. There are so many other things which are also important, and poll is exactly suggesting that you visit the stall, you visit the certain new things which they introduce. Sometimes they introduce new scope, sometimes they introduce some new equipment. So you get the feeling on hand actually there. So those are the other benefits which are there. Rajeev TP.
So you have to unmute yourself, Rajeev TP, sir.
You have been attending the webinars for quite a long time now since it has started. USI has jumped into it in a very aggressive way. There was a one-day full day this youth conclave. Do you think that the people who are actually attending the conference in a virtual way are able to concentrate for the whole 6 to 8 hours, the thing which you are actually organizing? What is your experience of that?
And my opinion is that more than 90% will not be sitting through the whole 8 hours or 9 hours, the whole day program. And they will be a pick and choose among the things what they like most, they will come and sing. This is what I have come across during almost all the webinars. If it is a 2 hour, 2.5 hours, then a big chunk of viewers may sit through, but still there are people who log in, go away, and again come in. This has been the things I have been watching through all our webinars. Even though we have an average of 700 plus viewers, it doesn't mean that all have been sitting through the whole period. Correct. They have watched for half an hour, then log out, again log in. This is the trend which usually I've seen.
Yeah, I think that's a very, very realistic observation. And we have also seen that people, they just log in. They put their audio off, they put video off, and they keep roaming around, going to the hospital and they do everything. But you think that they are logged in.
Yeah.
So that is the thing which you really have to face. Rajeev, another point which I want to ask you is that you have delivered lots of lectures in the physical conferences and you have been giving lectures in the virtual conferences now. Do you think from the speaker's point of view, there is a difference? Because in physical conference, when you are actually going to the podium, you see the people you are watching, you see what is their reaction, you see what is the moderator, chairperson, what he is saying. And quite often you modify your lecture style, you hurry up, you do a lot of modification on the spot there, looking at the feedback, physical feedback, which you see from the various the people who are sitting there. What is your experience about it? Do you think it does not matter, or you think that makes a difference?
As far as the lecture is concerned, it doesn't matter, but to give a flavor to the lecture, you should be able to gauge what is the level of understanding of the audience in the lecture hall. That gives more pleasure and think that your talk has been well appreciated by the audience. But this lacks in a virtual platform.
Right. Last question which I want to ask you, that you are the USI secretary. Now, if you are given a choice that the conferences should be virtual or physical, what is your opinion? Forget the poll, forget the thing, forget everything. What is your choice? You are the USI secretary. Your choice matters.
So, definitely, sir. I love to have a physical congress.
Good, great. Thank you. Tushar, let's go to the next poll. Mute. You have to mute.
Sorry, really sorry for that. So yeah, the third question: should routine RIRS, PCNL, and URS continue to be done looking at the present status of COVID in our country? 58% of the respondents said yes, they can continue, and 42% said no, they should be deferred. It's almost a mixed bag of response, sir.
Yes. So I think when it comes to the RIRS or PCNL, most people, even in the COVID era, they want to do routine this work. Dr. Amelia, what do you think?
Yes.
Why people are thinking when they are not doing the laparoscopy, they want to go away from the robotic, even in the cancer, they don't want to take the chance. Whereas here, what they have opined is that even if it is an elective PCNL, RIRS, they would go ahead. What do you think are the reasons for that?
Yeah, it's interesting. They actually, the population here is quite split in the equal way. I definitely think that all the cancer procedures should have priority here. And I understand the problems about aerosol and the robot as has been already explained. But from the stone point of view, I think it's interesting that 58% of people think that they should continue because they actually understand that some of them may be urgent because stones postponed for 1 year, they could become problematic in terms of sepsis, of causing other complication that caused by the delay, clearly. But half of people just may think that it would be probably a benign disease and does it not need to be prioritized, and maybe cancer would, which I can understand the point actually.
Right. Another question which I want to put in, which when we are talking of a really changing trends in endourology, what we have seen is that those who centers and those who are very, very firm about giving general anesthesia for almost everything, PCNL or RIRS, even for RIRS, now they have started for last 3 months doing under spinal anesthesia, epidural anesthesia. And you also pointed out that in your lecture, that people are doing the regional anesthesia and overcoming the problems of the regional anesthesia. Do you think that once the COVID era is gone, maybe 1 year later or so, this trend will continue to do the procedures under the regional anesthesia, or will switch back to the general anesthesia? What do you think?
Yeah, I think it's a skill that can be actually quite helpful to have. So probably we could continue. This trend can continue even after COVID, because once we understand which protocols can be done in stone patients to safely conduct a ureteroscopy under spinal or regional anesthesia, then automatically in the future, all patients who are not fit for general anesthesia will be done under local regional anesthesia. And this is a very good way to start. And I think there's a good possibility that it's going to continue in the future. Yes.
Right. So I think that's a very, very valid point, that once you get used to this spinal anesthesia, even RIRS with the spinal anesthesia, I think even the patient is completely fit for the general anesthesia. Some people might continue to do it under regional anesthesia, and that probably will be a really a big, I would say, the contribution by this COVID, where they really put us into the new normal, what we would consider.
I agree.
Thank you very much for your great presentation and for this.
Thank you.
Tushar, let's go for the next the poll.
Right, sir. Rahul, can we have the fourth question, please? Yes. The fourth question: what has been the real reason for resurgent publications since March? I think this is a burning question. 43% of the people said they have spare time to dig up existing data and write. 36% of the respondents said you fortunately to use COVID as a context to publish a paper. 14% feel there is more zeal to contribute to COVID research in urology, and 7% said they had the fear of missing out or because of peer pressure.
Yeah, so there are so different opinions. Rajeev Kumar, this very, very interesting that you actually covered most of the aspects in your presentation. But one thing which I want to ask you is that many journals which are actually not the open access journals, but now with this COVID articles, they have become open access, especially the articles which are related to the to COVID. Now, do you think that over a period of time, many of these journals actually switch completely to the open access, or this is only temporary phenomenon? There are other implications of not having the open access, and they will take the priority. What do you think?
So open access is basically two aspects to it. The reason journals are not open access is because they have to make money. That is the bottom line as to why big journals are not open access, because they have to make money for people to access their articles. So somebody has to pay. Till now, the concept or the model used to be that the reader used to pay. So if you wanted to read an article, you would pay to get it. That is progressively changing all over the world. There are massive plans, for example, Plan S in the European Union. There are other plans, for example, the NIH and the NHS, and all these funded organizations make it mandatory for you to publish your research in a manner that it is open access to the readers. So what is changing now is that journals want either the authors to pay, or they're looking at societies to pay. Therefore, the change in practice to open access is progressive. It's going to happen all around the world. It's already happening. Every journal gives you the option upfront that if you pay me, I won't charge the reader. So you're open access. Why do they do it for COVID specifically? There are two reasons. One, it is mandated by a number of organizations who have funded the research which is to be published. So that organization is already paid, the author is already paid, then the journal has made its money. The second reason is that if you publish a good article, let's say Lancet publishes an article which is open access, it will certainly get tons of citations because everybody can read it. Yes. And therefore the impact factor will automatically rise. So these are very well-defined strategies which journals and publishing houses use, where they balance their revenues with their citations, because increased citation translates into increased revenue. So it's a cycle. That's the concept behind open access.
Correct. So that's a very, very important factor. I want to ask two more questions to you. Now, you very lucidly said that the interval has really gone down from 150 days to just 15 or 20 days. And even for non-COVID articles, the articles are very, very fast. Do you think either from the other journal point of view or from the Indian journal point of view, they have bypassed the norms of going to the multiple reviewers instead of going through 4 or 5 reviewers, 1, 2nd, 3rd revision? Do you think that somewhere down the line, the editorial committee has reduced the norms of accepting the articles just because the journal also has to keep in race with the either COVID or non-COVID articles? Do you think that has really happened?
So very good question. Unfortunately, most of the authors who submitted to the IJU will not agree with that their reviewers have become more accommodating or have become less strict. So what we have found is that right at the beginning of April, I sent off an email as an editor to almost all our reviewers and members of our editorial board that we are getting a flurry of submissions. All of you are going to get more work over the next 2 or 3 months. And all the editorial board members and our regular reviewers replied saying, we are up to it, give us more articles, we'll work on them. And therefore our reviewers, who possibly also have more free time on their hand because they're not operating, were accommodating and gave us reviews back much more quickly than they would normally have done in their normal life cycle. So that is one reason why everybody has been specifically geared to giving us reviews quicker. We've also been able to process them quicker. So that's one reason why it has been quicker. I don't think it will sustain. Once you go back to your clinics, these are the same people who are operating from 8 a.m. to 8 p.m. and therefore they will not review at the same speed. So that is one reason why we were quicker. And second, yes, we are also in a race. We are also have a fear of missing out. So if I get an article on COVID, which I think is timely and I need to get it out quickly, I will call up, make phone calls to the reviewers, send them personal emails that I want a review back in 4 days, I want a review back in 5 days. and they will oblige, and then we will cut short. So we went on many articles, we went ahead on print much quicker than they were even published in the article. So it works both ways. But at no place will we accept that we have compromised on the quality. Some of the rejections that we have had have got published at other places. That's a part of our game. That's a part of the deal. But we've been quicker, but not necessarily shorter in our evaluation processes.
So last question, as an editor of Indian Journal of Urology, are you going to become stricter now? Because now you have seen that if you make a phone call and if you become strict, instead of 3 weeks, they will give you in 2 weeks. Instead of 2 weeks, they will give in 1 week. So has this COVID era has brought strictness in you? What do you think?
No, it won't change. So you see, how many personal favors can I take? And the only reason I can take personal favor is because I'm not operating and they're not operating either. Therefore, I'm sitting at my computer desk practically 6 hours a day, rushing through everything that comes in. There are people who possibly got a rejection in 8 hours because they were unfortunate enough to submit it while I was reading it. I quickly sent it to somebody else. He sent it back the same day. In 8 hours, he got a rejection.
Right.
So it's not going to sustain. It's because all of us have time on our hand. And we've also been wanting to do it quickly. That's why it's happened. It's going to go back. But let's hope some of it stays with us. Let's hope some parts.
Sir, I think even whether from an author's perspective or from a reviewer's perspective, from both perspectives, I can tell you that things have become more difficult for us.
Okay.
When it comes to IGU.
That's not a nice thing to hear. We're not trying to make life more difficult for you, but we've just got so many submissions, and people believe that just because I've done a survey of 300 subjects, I should get published. And I have got at least, half a dozen or more. And therefore it becomes even more difficult and you have to be stringent. So we are not trying to make your life more difficult. We are not trying to be more choosy, but we need to maintain our existing standards.
I think this is a message to everyone who is watching this changing trend, that Rajeev Kumar is not going to become lax. He's going to become more and more strict.
No, not more strict. No change. No change at all.
Knowing him, he's not going to let anyone off the hook very soon anyway. Okay, I'm a student, I know that.
Yeah, Tushar, let's go for the last poll result.
Sure, sir. Rahul, can we have this? Yes. So the fifth question on uro-oncology: do you feel confident in triaging various urological malignancies for treatment in light of the ongoing pandemic? 56% said, no, I'm not aware. Okay. 22% said, yes, I'm confident. 22% said, I have a rough idea.
I think I should have continued speaking for half an hour more, I guess.
Yes, you needed half an hour more because 56% said they're not aware.
Next time we have to have a separate webinar on what is triaging and what is the changing trends. So that is what is the next need. But Gagan, I want to ask you one question, and you said, elaborated in your presentation very nicely, that at many places the active surveillance actually has taken the step which otherwise the non-COVID era you would never have thought of. I want to ask you one question that many times we have seen here in the COVID era that there are certain guidelines which are actually bypassed. In the sense that I know Bhaskar Suman, if he is still logged in, I knew from UK that the localized CA prostate, who otherwise were for the radical prostatectomy, people gave the LHRH analog injections. Now, do you think that the results of all these things, which otherwise they would not have given this hormonal injection and various other in malignancies, some off-guideline therapies, do you think they also will come in, the publication will come in, and that will be a real eye-opener? What do you think? Do you think there is a chance of having that?
So firstly, I think whether in COVID era, non-COVID era, all the treatment should be done on the basis of the evidence that is available.
Yeah,
so
I think with the COVID, things changed and people started waiting and people started giving some
correct, sir.
Which actually were not
with
in
the as far as the specific thing about just give me 1 second. Alexa started speaking on her own. So I think as far as the specific question about LHRH analog is concerned, I think it's very clear. Everybody knows that giving it does not help patients when you're talking about surgery as the treatment option for localized prostate cancer. But in spite of that, whether in COVID or not in COVID, people have been giving LHRH analog. And I believe it is more about reassuring the psyche of the patient. It's more like a placebo, a psychological satisfaction that some treatment has been given, though the benefit of that thing is not proven. I do not think that this is going to prompt any further research on this particular subject, but I do believe that we as the practicing urologists need to
unmute.
Whether in the COVID era or not COVID or in the non-COVID era, we do need to follow the guidelines.
Gagan, just last, I want to ask your experience as the last question, that you have seen that in the beginning when the COVID came in, the work was almost standstill, even the malignancies were not being done. Do you think that the mortality or the morbidity of the operation really has gone up just because you waited for 1 month, you waited for 2 months? Do you think in your practice that has happened?
Sir, I don't think that as far as most uro-oncological malignancies go, we have missed the bus in the last 3 months. I think as far as T3, kidney cancer, muscle invasive bladder cancer, if you look at these like few exceptions, 1 or 2 points in each of the malignancies, we need to operate them as fast as possible. But for the vast bulk, I don't think we have missed the bus. But like I said in the talk, we don't know when it's going to end. We don't know whether we are going to be able to do everything in the next 3 months or whether it's going to be in 6 months. So if we stretch it out further and if we don't normalize our uro-oncological practice within the next 3 months or 6 months, in that particular timeline, we may see a flood of more advanced cases towards the end of the year or in the beginning of the next year. So to prevent that, I think that message that we need to convey to our patients is that if you have a problem which requires an urgent surgery, don't sit at home, come get operated.
All right, thank you very much. I think it is really creditable that even at this point of time when there are so many parallel webinars which are happening, we have more than 320 viewers who are actually logged in live. So that really speaks about the efforts which Dr. Tushar, Dr. Zeeshan, they have put in, and the great work that faculty has put in putting up the presentation. We are 3 minutes overshot, but over to you, Dr. Tushar, and then Dr. Zeeshan.
I think we are good. So I think we are done with the question answer session. That was a great question answer session. I would like to invite now Dr. Zeeshan for the closing remarks for this webinar. He was the convener for this webinar.
I didn't know I'm supposed to give a closing remarks, but I'm grateful to moderators for such a smooth run of this webinar and the fabulous speakers. All of you have done such a great job, and all the speakers were really good. And I myself have learned a lot from Rajeev Kumar sir about publication. I'm going to keep reminding him next time when we send some papers. And also excellent talk by Gagan sir about triaging. I think, sir, you need to take, as sir said, you need to have another webinar where you have to tell more on triaging to the people. I think people were fascinated by your looks that they didn't hear what you said.
Now you're really pulling my leg.
That's a changing trend that he also can pull the legs.
Then we can't say anything to him under the current circumstances.
Yeah.
Dr. Rajeev TP sir has given an excellent presentation showing all the numbers, because till now we have seen only the webinars being conducted, but he exactly gave us the numbers, how many people have attended, how many webinars being done. I'm sure that he's out of topic for the next few webinars. I hope that there's a pause someday. And also thankful to Amelia for taking her time out and excellent presentation where she gave an overview on endourology practice. And my friend Abhishek, I can't say much to him because he's an amazing speaker, and he's a perfect person to talk on training. So thanks to all, and thanks to Sun Pharma for giving us this platform to conduct this. Especially Vivek and Rahul have been a great support for this webinar. Thank you, Sabnis sir, and thank you, Tushar.
Thank you, Zeeshan. I think you thought of this program very well, and you and Tushar executed these whole topics in a fantastic manner. So the 100% credit to you.
Thank you, sir. Thank you. And thanks to my crew. I forgot about
Thank you, everyone.
Thank you, everyone.
Thank you.
Thank you.
Thank you. Thank you.